Hi everybody, I'm Dr. Deed Harrison, and if you've been following these, we're doing near weekly video research presentations covering the CBP nonprofit research publications in the peer-reviewed literature. This week I'm going to go through one of our projects from 2005. This is our 34th video, so we've done 33 other ones. Hopefully you're following us on the YouTube channel and checking these out. This week we're going through the following paper, determining the relationship between cervical lordosis and neck complaints. That means the curve from your side and the presence or absence of pain. This was published in the Journal of Manipulative and Physiological Therapeutics, 2005, volume 28, page 187 through 193. The lead author on this is my good friend, CBP instructor, and scoliosis pioneer and innovator, Dr. Jeb McAveeney from Australia. His colleague and co-author, Dan Schultz, who's now a chiropractor, and then their other colleague, Richard Bach, and he's also now a chiropractor. Then myself, Deed Harrison, and then the late Bert Holland, PhD from Temple University, the Department of Statistics. Now this was a chiropractic master's project. This is for graduation in Australia, Macquarie University in Sydney. The chiropractors have to complete, or the students to become a chiropractor have to complete a master's thesis. And this is Dr. Jeb's, Dr. Dan's, and Dr. Richard's master's thesis project. I got invited to collaborate and co-author on the project as a senior member and a senior supervisor, and then we contracted with Dr. Bert Holland, PhD, to help us with the statistics. So just let me give you a little bit of background. Still today there's a debate in the literature on whether or not a cervical curve is needed for the health of the human being. So some people believe and argue that there's no correlation between loss of the cervical curvature from the side, so the neck curve from the side, or reverse cervical curves and any type of health complaints. And then there's people like me and my group of doctors that we argue that there is a relationship and correlation between human health conditions and loss or reversals of the cervical curve. Now, I'm not here to say that this paper answers the entire issue, but I am here to tell you that this is actually one of the best projects at the time, 2005, and still today on this very topic. So shown is an abnormal cervical curve on the left side of the screen, and then a perfect normal cervical curve on the right side of the screen. And the theory is the person that has a normal or near normal curve is going to do better. They're going to have less spinal arthritis and disc disease. They're going to have less cervical complaints. They're going to have less health conditions like arm pain, asthma, allergies, things like that. That's the theory. And then the person on the left would be the opposite of that. They would have more spinal arthritis and disc disease. And just check out the destruction in their neck, and you can see this. These joints are damaged, the discs are damaged, there's bone spurs, etc. This person should have increased neck pain, increased stiffness, maybe arm pain, weakness, numbness, tingling, and maybe a host of other conditions. That's the theory, right? Well, let me give you the controversy of this problem, and it still exists today. This comes from 2008, and this is basically a summary statement from a paper that was written in the same journal that our paper is in. This was 3 years after our paper, and this was by two authors doing what's called a systematic literature review. Here's what they concluded in their literature review. The evidence from epidemiological studies does not support an association between sagittal spine curves, that means the neck curve from the side, and any health condition including spinal pain. Now, this particular paper, I'm going to, in a video, critique the heck out of it through a paper that we had published in a different journal. And I'm going to maybe do that next week, so it goes back to back with what this particular study is going through. This particular paper, to me, is fraught with problems. They ignored many, many papers in the literature, and they actually misrepresented and misrated a couple papers. And so I'm here to tell you my personal perspective and opinion on this paper right here. It's nothing more than an agenda piece. The authors had a conclusion in mind, and they figured out how to reach that conclusion. Now, that's my opinion. That's very strong, but I'm entitled to my opinion, and next week you'll see why I say that. Based on that paper in 2008, a neck pain task force to develop guidelines for the chiropractic profession put this out in 2009. And this was a panel of approximately 40 so-called experts in the chiropractic realm, and what their task was to do is to set forth the best available evidence out there and look at whether or not certain treatment strategies are what we call evidence-based and needed, and whether or not certain conditions in the spine are worthy of consideration, and do those conditions cause or correlate to a patient's health and disease. So if you look at this is called the CCGPP Neck Pain Task Force Guideline. This was in 2009. Using the previous paper that I just showed you from 2008, here's what they concluded. The team discussed the issue of the cervical curve of the neck and treatments directed at this. We determined that there is no evidence that alterations in the cervical curve have a relationship with neck pain. None. They said none, no evidence, and related disorders. This finding thus will not be considered a neck-related disorder, and we will not include this in our chapter. They're talking about the neck curve. They're not even going to consider it as a neck disorder. This is the kind of thing that exists in the literature. Now, I'm here to tell you, my opinion on this is an agenda. The reason this is an agenda is because if a group like this determines that the neck curve from the side is a clinically significant finding and it warrants treatment, then insurance companies using this guideline would now be mandated to pay for treatment directed at and dictated towards restoration of the abnormal cervical curve. Since it takes at least 30 to 40 visits to correct the neck curve from the side in the average adult that has a loss of their neck curve, now the insurance company will be mandated to pay for 30 to 40 visits. So I'm here to tell you my opinion on this is that this is an agenda to make sure that third-party payers don't have to pay for treatment directed to rehabilitate the cervical curve. Now you might go, oh, dude, that's a conspiracy theory. Hey, bring it on. I'm a definite conspiracy theory believer. When it comes to financial interests, you bet that there's going to be a conspiracy theory and agenda. Right? So now that that's been said, here's what, that's the flip side of the equation. Let's look at this. Let's look at whether or not there's actually evidence out there that says or indicates that the cervical curve is an important outcome. And let's go outside the chiropractic profession. Those previous two papers, if you will, one's a guideline committee, one's an actual publication. Those are in the chiropractic literature. Let's go outside the chiropractic literature and just let's look at this. By Villavicencio, a prospective randomized double-blind clinical study evaluating the correlation of clinical outcomes after single-level surgery in the neck and cervical curve alignment, published in one of the top journals in the world, Neurosurgery, volume 68, pages 1309 through 1316, 2011. Here's what they did. They looked at 122 patients, followed them for 3 years. Now these people had discogenic herniation or mild to moderate stenosis at one level, where they needed a decompression surgery and a fusion at one level. Excuse me, it was one level, not mild, sorry, moderate. Okay, so here's what they looked at. Number one, the study looked at two different types of surgical instrumentation and methodology. I don't want to get into that part of the study. What I want to look at is the outcomes. Here's what they identified. Patients who had maintained or improved the segmental sagittal alignment of their cervical curve, regardless of the surgical type, achieved a higher degree of improvement in the SF-36, that's a health status questionnaire that's validated across countries and cultures and pain conditions, in the physical component and in the neck disability index. In other words, they identified statistically significant outcomes for neck pain and disability and physical function based on the amount of cervical curve that the patient had attained post-surgically. Now that tells me that there's a relationship between the cervical curve, neck pain, and disability, contrary to what was, suggested in the previous two papers. Now keep in mind this came out 3 years later, but this is one of the best studies that you can do to look at the outcome. This is a double-blind, randomized clinical control trial with a 3-year follow-up. Excuse me, I got a piece of hair, not for me because I don't have much up there, but it's itching me, so sorry about that. All right, so now I've set the stage, I've shown the pros and the cons and the debate on each side, and I've put myself in the hot seat because I've made some very, very strong statements with my opinions on this. And you know what? Hey, you either stand for something or you fall for anything. And anybody that knows me, I'm extremely direct, I'm very blunt, you're never going to wonder where I stand on an issue. That's just the reality of it. I can be politically correct, but in cases that I don't think I need to be politically correct, I'm not going to. This is about health care. This is about the needs of the patient. This is not about somebody's agenda to try to improve profits for some company out there, right? I favor the patient in the equation. That's my job. I'm a clinical researcher and a clinician, and that's what I do. I do not like it when I see that patient claims and things like this are simply being denied because somebody else doesn't want to pay for it. All right, back to this. This particular project, here's what we did. 277 patients were randomly selected from an outpatient clinic at Macquarie University, okay, called the Summerhill Outpatient Clinic. Now, this is a retrospective random sample. However, what we're looking at is two things. Number one group is going to have subacute or chronic neck complaints. No recent history of trauma was allowed. Number two, we also pulled from a population that were simply evaluated from a spinal screening. They weren't coming in as a pain subject. They came in as a spinal screening subject that just says, oh yeah, go ahead and check me out. I don't have neck complaints or upper back complaints or headaches. So we truly have a pain sample versus a non-pain sample. 277 subjects randomly pulled from the files at Macquarie University in their outpatient clinic. The average age was 38 years old. However, importantly, there's an age range from 9 to 78. And you'll see what we did to analyze this broad age range, because you can't compare 9-year-old subjects to 78-year-old subjects. What we have to do is compare each age bracket within the two populations of pain versus non-pain. Okay, 55% of the subjects were female, 45% is male, which is a pretty equal gender distribution. And then what we looked at was the total cervical curve C2 to C7. I'll show you a picture coming up. How much forward head translation might be present on the lateral cervical curve from C2 to C7 or C1 to T1, and then pain scores. Okay, now we excluded the following. Anybody that had significant degenerative spine change in their neck, we're going to exclude, because that has been weakly to moderately correlated to the presence of pain. We don't want confounding issues in the data, because then we don't know, is it the curve that's causing the pain, or maybe causing the pain, or is it the spine degeneration that might be causing the pain? Okay, so we exclude degeneration. We exclude anomalies. That means variations in anatomy that would affect the curve. We exclude instabilities in the spine, so a segment that's truly unstable and injured. And we also excluded fractures, and also we excluded any recent trauma. So anybody that had pain that was acute inside the last 12 weeks or 3 months, they were not part of this. We're truly looking at what's called subacute and more chronic pain population here. So here's our exclusion criteria, and then you now know our inclusion criteria. There's one other that's not shown here, and I'll explain with the x-ray measurements. So here's the x-ray measurements that were used. We used two. We used the middle one, the ARA, absolute rotation angle for assessment of the total angle of curve. C2 to C7, the back of the body of each vertebra, we draw a line on the back of the body of C2 and compare it to the line on the back of the body of C7. Those two lines make an angle. My late father called that the absolute rotation angle, total angle of curve, C2 to C7. So that angle, total angle of curve, is what we used. We also used C1 to T1 vertical offset called translation, or C2 to C7 vertical offset, depending on what was seen on the film. Okay, so this is a measurement of how far the top of the neck is in front of the bottom of the neck, indicative of anterior head translation. Okay, so we included that. Now, what should have been included in the student project, but I'm going to make a joke here, don't get mad. The students, Jeb told me, he goes, man, we're lazy. We're not doing this. We had to do it by hand. They didn't have a computer system back in the day that you could just touch points on a vertebra. They actually had to make these measurements by hand. And I said, hey, Jeb and the boys here, why didn't you make measurements of segmental angles? And they're like, D, do you know how many measurements that is? Times 277? I'm like, yeah, I know, but we need that data. The thing is, we need these segmental angles so we can see, is this a uniform curve or is it a non-uniform curve? The problem with only using the ARA, the C2 to C7, you could have a good measurement here, but you may have abnormal segments contributing to that. For example, let's say I have a 20-degree ARA. Well, maybe I have a reversed area in my lower neck and then a lot of curve in my upper neck, and it gives me that 20 degrees, right? So the problem is, just using this one measurement, you can't actually decide, does somebody have an S curve, like reversal down low or reversal up high? Now, using this measurement, it'll tell you if somebody's lordotic, if they're straight, or if they're kyphotic, if you exclude the S curves. So what we had to do in this project, the student researchers here, Jeb, Dan, and Richard, they had to go and they had to exclude all the S curves from their population because of the fact that they weren't making the segmental measurements. They only had the total angle of curve. Now I'm happier. Now I can go, okay, I got lordotic necks, I got straight necks, and I got true reversed necks. I got 3 types of necks, and this measurement can discriminate between those. So this is one of the exclusion criteria in the study, and it has to be done if you're not going to make the segmental measurements. Here's the type of pain subjects that were included in the study. Now, these are classically what comes into the chiropractor or goes to a PT or an MD. Hey, I got chronic neck pain. It may be anywhere from the back, top, or the sides of the skull all the way down to the upper thoracic spine. And if you're a patient out there, you go, wait a minute, no. I hurt my upper thoracic, my scapular region, my shoulder region. That's not from my neck. Yes, it is from your neck. You feel it in the upper back or shoulder area, but the source of the problem is in your neck. It's what we call sclerotogenous pain. For example, these different colored maps show where each joint in the cervical spine will refer or cause pain to the neck and the head and the upper back when it's irritated. It's what we call the facet capsular ligament pain distribution patterns. They call it sclerotogenous pain, sclerotomes after embryology. So here, if I take the C2 to C3 joint in the neck, that's right near the top of the skull, or excuse me, the base of the skull, it'll actually cause pain to go above the ear just below the top of the skull. Now, if I go down to the lower neck, the C6 to C7 joint, look how far it can cause pain. It can go all the way through the shoulder blade, all the way down to the mid-thoracic spine almost, right? And then it can cause pain into the trapezius area. Now, the patient, it's very hard for you to understand that. It's just the way neuroanatomy works. Where you feel pain may not be where the problem is. For example, when you, and hopefully none of you have experienced this, but most of us know somebody that has had a heart condition or maybe a mild to moderate heart attack. And one of the first signs of a heart problem is left arm pain and numbness, or left shoulder pain and numbness. Well, how can that be? The problem's in my heart. Well, just so happens that that area, the heart, interacts with the nerves that control and coordinate, pain sensation in the upper extremity on the left side. So it's very common to get left upper shoulder pain and arm pain and numbness, etc. with a heart condition. This is the same thing. Now, that being said, this is the type of distribution of the pain that we were studying in this particular population. So these subjects could not have true what we call forehead headache pain that may or may not be from the cervical spine. So we isolated it to this region. Okay? Here's what we identified, the meat and the potatoes. In our population, the patients with neck pain statistically were twice as likely to have curves below 20 degrees using that C2 to C7 measurement. Okay? Statistically, this was an important cutoff. So if you're less than 20 degrees, you're in the pain group. Okay? If you're greater than 20, you're in the normal subject group. And I'll show you a graph that really reinforces this and makes it, easier to understand. And then this one, number 2, is a big, big finding. And I've bolded it and underlined it. The odds that a patient with neck pain having a cervical curve that's straight or kyphotic, that's what that means. So if your neck is straight or reversed kyphotic, that is 18 times more common in the neck pain subjects than in the non-pain subjects. This is a huge odds ratio. 18 times. You're 18 times more likely to have neck pain if you have a straight neck or a reverse neck curve compared to somebody that doesn't. That's what that means. That's a huge statistically significant finding in this paper. It's probably the most important finding, okay? Thus, I've kind of emphasized that for you. You probably won't forget it. I'll show you a graph that gets back to that and shows you the distribution of these curves. Decreased cervical curves, that means less than 20 degrees, in the pain population was consistent over all the ages. In other words, there was no trend in the cervical curve angle changing as the patient aged in my different populations with neck pain versus no neck pain. In other words, if you were 9 years old, 9, so that's a child, if you had loss of the cervical curve less than 20, you were more likely to be a pain subject than a non-pain subject. And yes, 9-year-olds do have neck pain. 9-year-olds do have health problems. They are not just making it up. Why do they have health problems? Well, look what they do. They're on trampolines. They're on bikes. They're wrestling around. They're taking head and neck, spills. And if it damages their cervical curve, it's going to set the stage for a problem. In this case, the problem that was identified was when you lose your curve less than 20 degrees, you're statistically more likely to have neck pain when you're 9 years old. Okay, now I'm just going to show you some data and some charts because it reinforces the study findings, right? The distribution of pain and gender. Okay, so gender, male or female. This is the number of patients with no pain. So this is the spinal screening subjects that didn't come in for a complaint. They just said, yeah, check me out. Let's see what my neck looks like. So there's 58 men with no pain and 41 women. So we've got 99 asymptomatic subjects. And then over here, we have 178, if I can do my math off the top of my head, right? 178 pain subjects. There's 83 men and 95 women. Yeah, there's a little more subjects with pain, but that's because, the average person that's asymptomatic doesn't have pain. They typically don't want to go get checked up, right? So we got 99 in this group and 178 in this group. Cervical curve by gender. Now here's the distribution by whether you're a male or female in your curve and by decade of life. This is very important. So here's the angle of curve here, right? If you're 0, that means straight. If you're above 0, this means you have a good curve, a lordosis. And if you're below 0, it means you're reversed or what we call kyphotic, okay? So right here is what we call the median value in each population sample. Now these are the samples of subjects less than 20 years of age. These are the subjects between 20 and 29. These are the subjects 30 to 39. These are the subjects 40 to 49. And then we looked at people all the way up to greater than 59 or 60 years plus. So here's what this box plot with what we call standard deviations in the median shows. Males on average had a slightly higher median cervical curve, C2 to C7. And this was statistically significant, 20 versus 14 degrees. So in our population, males had a bit more curve than females. Females, though, had larger variability in the ARA, the cervical curve. However, the trend was only statistically significant between the 40 and 49-year-old age range. That means right here, if you look, this clearly shows a much bigger difference between females and males than at the other decades. So it's only statistically significant at this decade. Why? Don't really know. Really, the answer is we don't really know. Okay, so the trend is that males have more curve, but it's only significant in the fourth decade of life. Okay, and in fact, the opposite tends to happen as we get older. Now, this one we kind of understand. Greater than 59, meaning 60 years and up, this is where women, unfortunately, a lot of osteoporosis. They're starting to develop a lot of thoracic hyperkyphosis, so then the neck goes forward and tips backwards, increasing the female's cervical curve. This may not be a good thing for women above the age of 60 because classically it might be a spine deformity in the thoracic spine and even the lumbar spine that's driving this increase in neck curve. The cervical curve by age and pain status. Here's one of the most important things that we found. Doesn't matter what age group you're in, if you have pain, you have a reduced cervical curve. So let's look at less than 20. If you're under 20 years of age, other means no pain. Look at where the other subjects sit. They're above 20 degrees. Look at where the pain subjects sit. They're really close to 0 degrees. Really close to 0. There are strong statistical differences between these groups. You can look at each decade as we've delineated it out, and you'll find out that that holds true. No matter your age, if you have pain, you had a reduced cervical curve compared to subjects that are age-matched and did not. And we also did gender matching in this. So we looked at gender influences and age influences, and we found that the cervical curve is reduced in the pain subjects, no matter if you're male or female, no matter if you're young or old. This is a very important finding. Look at this. I'm going to summarize it again. Cervical pain tends to have a decreased cervical curve angle. This is consistent over all age decades studied. Patients with cervical pain had more variability in their neck curves than those without. That's a common finding too, right? There's more variability in the distribution. The non-pain subjects are more tightly centered. The relationship of cervical curve and pain. Now this is an important one. What we did was we separated this not by age and gender, but we separated this by 5-degree increments of the cervical curve. So you can really see when the most significant finding is present at what amount of cervical curve. So we've got two colors. This blue color is people that have cervical pain. Okay, and then down here is how much cervical curve they have. Now the purple color is people without cervical pain. And then right here, this graph is the percentage of people that had complaints. So what percentage of these people that fit curves in this range actually had cervical complaints in this population? Okay, so let me explain this to you. 0 degrees or less than 0. That's what that means. So if you have a straight neck or kyphotic neck, look at this. The percentage of people that had pain is huge. It's almost 100%. In the normal subjects, the percentage of subjects that were here, it's very, very small. It's very, very small. Okay? Now, so the greatest difference here is for curves that are approaching zero, or are going reversed the wrong way. Now, you'll start to notice the two colors start to change, and right here they change directions. Now there's more people without pain than there are people with pain, right at this 21 to 25 degree mark. What does that tell me? Well, it tells me most of the pain people are sitting in here. Okay, most of the pain people. And then when I go closer to 20 degrees, I go, whoa, now most of the asymptomatic people are starting to sit here. And then I look at this and I go, where is the biggest difference between these two populations, no pain and pain? Where are the fewest people with pain and the greatest number without pain, right, in terms of percentages? And notice what we see is the 30 to 40 degree range is like this window. It's like, wow, that's interesting. 30 to 40 degrees of a cervical curve seems to be the protective value or range for this cervical curve in terms of protecting you from neck pain. And then all of a sudden, if we go above 40 degrees, you'll notice that trend changes. Now, caution. Above 40 degrees, there was not enough in our sample to actually do proper statistics. So we don't know above 40 degrees if that's statistically significant. We don't know that. What we do know is the other stuff, though, is clinically and statistically significant. Very important. Now, here's the distribution across all the subjects based on their curve and their pain. And let me explain this one to you. This is a really interesting graph that we did. It's called a dot plot. Okay, now number one, the angle of curve is down on the bottom. If you're 0, you're a straight neck. If you're less than 0, you're a reversed cervical curve. Number two, the bottom line is the asymptomatic normal subjects. Number two, the top line is the neck pain subjects. Okay, so all the subjects with neck pain are on the top. All the subjects without neck pain are on the bottom. Each dot is one person. Okay, so each dot is one person. So let's start with the normal subjects. How many normal subjects of our 99 people had a straight neck, a true straight neck? One dot, one person. How many of our normal subjects had a reversed curve, a curve going the wrong way? 2 dots, 2 people. So how many people there? 3 people in the no pain group. 3 people. Now let's jump up to the pain subjects. How many of these pain subjects had no curve in their neck? Whoa, big difference. Way more than 1, right? Way more. And then let's look at this. How many people with pain had reverse cervical curves? Right? Now, what we found, remember, we said an 18 times odds ratio. Now, what that means is you got 1, 2, 3 subjects normal down here. How many subjects do you have up here? I don't want to count these dots. Let me just do some math for you. 18 times 3, 54, right? Sorry for making you do higher mathematics, a little multiplication on a video for you. 18 times 3, 54. And hope to God I got the answer right? So anyway, I got 54 subjects here. That's a huge finding. Now, let's go to the 20 degree mark. Above 20 degrees, guess where most of my pain subjects don't sit? Most of my pain subjects are actually below 20 degrees. Most of my non-pain subjects are above 20 degrees. 20 degrees happens to be the statistically significant cutoff value. Okay, we'll talk about that coming up in the next slide. Now look at the window, 30 to 40 degrees. How many subjects with pain sit in that window? Very few. How many subjects without pain, no pain, sit in that window? There's a lot. So what we see from this dot plot is it kind of visually explains everything that I've just gone through with you in terms of the meaning of how much curve somebody should have, right? When we look at this data, we conclude this. Above 20 degrees is a statistically significant cut point where people don't have pain from a cervical curve. Below 20 degrees is where people start to have pain. If you're a straight neck or a kyphotic neck, you're 18 times more likely to be in a neck pain group than in a normal group. This is a huge finding. And then above 40 degrees, there's very few subjects. We can't do statistics on that. You can see a weak difference. We don't know if that would hold true. Okay? Now, This might go over some of your heads. If you're a doctor, great. If you're a patient, you may or may not understand this one. This is what we call receiver-operator characteristic curves, or ROC curves. This is where we look at something called sensitivity and specificity. This is where we look at true positives versus true negatives, and false positives versus false negatives. Now, receiver operating characteristic curves, they tell me whether or not I've got good sensitivity and specificity of a variable, like the cervical curve, being a dichotomous cut point between two or more populations, a neck pain and a normal population, for example. ROC curves are very important because it tells us, do we truly have a significant finding here? And here's what we identified. We identified, using the area under the ROC curve, that the 20-degree cervical lordosis has good sensitivity and good specificity. Okay? In other words, it's the one that minimizes what we call false positives and false negatives. It's the one that maximizes true positives and true negatives. Okay? So we know from this analysis, we're on to something here. If you're above 20 degrees, the receiver operating characteristic curve analysis shows that you're more likely to have no pain. If you're below 20 degrees with your neck curve, you're statistically more likely to have pain. That's what this shows. And I've just put some of the information in there about the ROC curve analysis so you could see that. And then, I'm sorry, it's cut off the area under the ROC curve, which is the area here. It's roughly 80%. And 100% would be perfect, 1.0. Very rare to find a single variable that does that. This is a good discriminator for neck pain and non-neck pain. Conclusion then, here's what we identified. These reverse neck curves, these are bad for you from a pain perspective. You're 18 times more likely to be in a pain group. These straight necks, same thing. You're 18 times more likely to be in a pain group. This one, even though it looks a little shallow for its cervical curve, this one would be about 20 to 25 degrees. This is considered okay. This is within normal limits. If you have a curve that's above 20 degrees, up to 40 degrees, this is a healthy neck lordosis or cervical curve from a pain perspective. It means this person's likely not going to have a lot of neck pain. These people over here, though, the odds are they're going to have neck pain. That's what we identified. So then, just to summarize that, if you look at the conclusions, I like to point this out again because I want to be clear. Here's what we identified. Patients with straight necks and kyphotic necks, that's reversed, were 18 times more likely to present with neck symptoms, cervicogenic complaints. This finding supports the theory that a straight neck or a kyphotic neck are actually abnormal from a pain perspective. We found a statistically significant association between cervical pain and cervical curves below 20 degrees. 20 degrees seems to be this magic number. If you're below it, you got a problem, right? Additionally, we found a clinically normal range for lordosis of 31 to 40 degrees, reflected by an increase in the number of cervical complaints above and below that range, especially below it, right? Above it, we didn't have enough samples. And then it should also say this 20-degree cut point, it's irregardless of age. Doesn't matter if you're 50 and up or if you're under 20 years of age. If you have less than a 20-degree cervical curve, you're more likely to have neck pain. Maintenance of a cervical curve in the range of 31 to 40 degrees and certainly above 20 degrees could be a clinical goal for chiropractic treatment outcomes. To me, this is one of the most important projects we've done. This was a project done at a university, the chiropractic department at Macquarie University. So hats off to the young men at that time, Dr. Jeb, Dr. Dan, and Dr. Richard. And I'm really honored to have been invited and part of this particular project. Very important to see a group independently evaluate some of the work that we did in CBP. And if Dr. Jeb McAvini was here, he'd tell you this. This is a quote from Jeb. Jeb and I didn't know each other at this time. We got connected after their preliminary analysis showed something of interest. He said, hey, I would like to contact Deed Harrison. And I was already, of course, graduated, so it was Dr. Harrison to Jeb, right? And Jeb basically told me, he goes, you know what, I set out to do this project to prove that CBP was wrong. My initial goal was to prove that there's no relationship between the cervical curve and pain. So he set out to prove the other thing as compared to what was found. This is a very important thing, and you could contact him and you could verify that for yourself. That's a very important thing. He didn't set out to prove that the cervical curve was related to complaints. In fact, he set out to do the opposite. That was his initial goal with doing this project. However, since this time, he's like, wow, there is a relationship between the cervical curve and complaints. I'm on board with it. I want to do something to correct my spine and my patient's spines. That being said, hopefully you enjoyed this week's video presentation. Hopefully you accept me for who I am and what I say. I can be a little off color sometimes and a little bit direct, but you know what? It's my opinion. I'm sticking to it, but I back it up with data. If you're a patient out there and you've got neck pain or you've got arm pain, headaches, whatever condition it is, you might want to get your cervical curve checked out and go see a CBP trained chiropractor, right? If you go to other practitioners, they may say, oh, well, you know, there's no evidence that the cervical curve relates to neck pain or anything. You go to an MD or a surgeon, they might say the same thing, but I'm here to tell you, I think the best data and the overwhelming majority of that best data points to the fact that there's a relationship between the cervical curve and health outcomes. You got to realize this, you the patient, you're the one suffering out there. There is a reason for you to have the pain or the condition you have. You need to find out that reason, and then you need to do something to fix it. You don't want to go to somebody that says, oh, don't worry about it, right? No, you need to worry about it and do something about it. Let's get this taken care of. What can it hurt to try to correct your neck curve? It may in fact change your entire life and the way you look at things and the way you function. That being said, find a CBP trained chiropractor at cbppatient.com. Also consider supporting CBP nonprofit research at our website, cbpnonprofit.com, or you can just support us through Amazon Smile. When you make purchases, you can select CBP or ChiropracticBio Physics nonprofit as your nonprofit organization, and then Amazon will turn around and donate 0.5% of your purchase back to spine research. Thank you for your time and attention. Until next week, have a great week.